by combination of the hypnosis, muscle relaxation, and analgesia. So what is the need of analgesia and what is the need of muscle relaxation along with the hypnosis? Because if we don't give analgesia, so because of the pain sensation, there are physiological responses that result in the elevation of the blood pressure and the heart rate. So that causes bad effects. And the other thing is that muscle relaxation, for example, if we need to do surgery in the abdomen or thorax, we need muscle relaxation for that purpose also, and that also aids into the intubation process. Phases of general anesthesia. There are 3 distinct phases of general anesthesia. Number 1 is the induction. Induction is just like to start the process. Okay, while the maintenance, this is how to maintain the anesthesia for the duration of the surgery, and recovery, as you can understand, this is the reversing of the effects of anesthesia. Now the stages basically means the depth of anesthesia. Okay, this is different from the phases of anesthesia. Phases of anesthesia is basically the process of anesthesia, while stages means the depth of anesthesia. And as you can see here, that stage 3, this is the surgical anesthesia that is required. Okay, but if we give more dose of anesthetic, that may result into the medullary paralysis. That means there will be a slower heart rate and we may lose the patient. So the induction agents, there are 2 types of inducing agents: intravenous agents and inhalational agents. Most commonly we are using intravenous agents for the purpose of induction, but we may also use inhalational agents, for example in children. Okay, children less than 10 years of age, we can use inhalational agent for the purpose of induction, and in those adults who don't like to be pricked by the needle, so we can use inhalational agent. And for the inhalational agent, sevoflurane, it is the one that we are using. Why only this gas we are using for the purpose of induction? Because this is sweet smelling and this is not irritant, so that's why this can be used for the inhalational purpose. Although we have other inhalational agents available in the market, but we don't use it for the purpose of induction. We are using those agents only for the purpose of maintenance. Okay, so intravenous agent, as you can see, there are a variety of intravenous agent that can be used for the purpose of induction, but propofol, it is the one that is most commonly used. Here you can see that there is a milky white liquid into the syringe. This is basically the propofol. This is basically lipid soluble drug. That's why its induction it's quite quick, and because it crosses the blood-brain barrier, and when it crosses the blood-brain barrier and reaches into the brain, so naturally it causes anesthesia. But remember that it diffuses back into the tissues as well, so that's why its duration of action is quite short. Okay, so if we have to maintain anesthesia, as we will understand in total intravenous anesthesia, then we can give as infusion, but for induction part only, as a single shot we have to give this. Okay, so as I told you that propofol, this is the most commonly used drug for the purpose of induction, but the problem is that since this is a lipid emulsion, so it causes pain at the site of injection, and it may also result into the arrhythmias. And other thing is that this lipid emulsion, if we are not careful enough, then there may be bacterial growth as well, so we have to be very careful about the sterilization of this. Thiopentone is basically barbiturate, and this is also used for the purpose of induction. but the problem is that it may cause myocardial depression and hypotension, so we have to be careful while inducing general anesthesia in a patient who is already in shock. So but it is very good when we have to use in the patient where there is need to reduce the intracranial pressure. Intermediate, it is very good for the induction purpose, and sometimes this is used as a whole agent, because if the procedure is very short, so that can be done only with the intermediate. For example, if we have to do for example reduce the reduction of the dislocated joints, or tracheal intubation, or cardioversion, or electroconvulsive therapy, so that can be used with the intermediate. Remember, intermediate we cannot give multiple doses because it may result in adrenocortical depression. Ketamine is a very good anesthetic agent, and that can also be used as a sole agent if the procedure is very short. For example, if we have to reduce any joint, or for example if we have to do incision drainage of an abscess, so that can be used. But remember that may result into the elevation of the blood pressure. So if patient is already hypertensive, so we have to avoid ketamine. What is rapid sequence induction? Because you know that sometimes we are receiving the patients in emergency who are not ready for the anesthesia because of the nil per oral time. So in that case, for example, patient is in the late trimesters of pregnancy, or already a patient has some diaphragmatic hernia. So in those cases we have to give rapid sequence induction, because there is chances of aspiration of the gut contents into the respiratory system. So to avoid that thing, we are giving rapid sequence induction. In rapid sequence induction, we are combining the ultra short acting barbiturate, and then we are giving depolarizing muscle relaxant, and quickly we have to intubate the patient. And during intubation, we have to give slight pressure over the tracheal ring, so that intubation is much easier and much quicker. This is called Selick maneuver. So in this picture you can see that there is slight pressure over the cricoid cartilage, so that intubation is much easier. And the other thing is that the chances of aspiration of the gastric contents are much lesser, because here you can see that there is pressure over the esophagus, so that the gastric contents are not coming into the respiratory system. Now, what about the total intravenous anesthesia? As the name suggests, that in this case we are not using the inhalational agents for the purpose of maintenance of anesthesia. Basically in this what we are doing the intravenous agents used for the induction as well as for the maintenance of the anesthesia, while routinely what we are using for the induction purpose, intravenous agent, that's routinely used, but for the maintenance of anesthesia, inhalational agents are routinely used. But in total intravenous anesthesia, what we are using intravenous agent for the induction as well as for the maintenance purpose. And how do we achieve this? We are combining propofol along with the ultra short acting opioid remifentanil, neuromuscular blockade. And here you can see that whatever the patient is inhaling, that is not the inhalational anesthetic agent, rather this is the mixture of air and oxygen. And what are the advantages? Because actually there is a lack of cumulative effect of the intravenous agent and with the inhalational agent. So that's why there is better hemodynamic stability and very good recovery profile, and that's why this is a very preferred type of anesthesia for the day case surgeries. Here you can see this is the machine that is used. Here you can see the propofol, the milky white liquid, and this is called as deprefuser or the target control infusion device. Here you can see it is written CPT, that means targeted plasma concentration. So after calculation you are entering the targeted plasma concentration, and here you can see CP, this is the plasma concentration, and that is actually how much drug is going into the patient. So that is telling you. Now, how to maintain the anesthesia, as we have discussed earlier, that we can maintain the anesthesia by intravenous agents and the inhalational agents, but remember, commonly we are using inhalational agents for the maintenance of anesthesia. But as we have discussed earlier, the total intravenous anesthesia, in which we are using propofol for the maintenance of anesthesia. And here you can see this is an inhalational agent, which is actually liquid at the ambient temperature, and we have to put this liquid into the this vaporizer. This vaporizer is along with every anesthesia machine, but remember that vaporizers are according to the drug used. So if for example I have to use isoflurane, so I will have to use vaporizer of isoflurane. I cannot use the vaporizer of any other drug. Okay, how do we manage the airway during general anesthesia? This is the most common maneuver just at the start of anesthesia, and if the procedure is very short and we don't have to use the endotracheal tube, we can maintain the airway just by chin lift and jaw thrust, but this is very rare. Usually we are maintaining the anesthesia by the endotracheal tube or laryngeal mask airways. So Giddle airway, as you already know, that it holds the tongue forwards but does not prevent aspiration. So that's why if the procedure is long, we cannot use the Giddle airway for the maintenance of anesthesia, for the maintenance of the airway. So, but if for example, if it is of very short duration, so we can use Giddle airway for the maintenance of airway. And when the patient is coming out of anesthesia in the recovery rooms, you have seen Giddle airway, because in that case also the patient is not able to hold his tongue. That's why we have to pass this Giddle airway. Here you can see how the anesthetist is holding the mask while maintaining the C and E position, so that he can maintain the position of the airway by tilting the head and lifting the chin. Here also you can see when the anesthetist is using both hands, how he is using both of his hands while maintaining the pressure over the mask and maintaining the airway. Giddle airway, actually we will take a skill class, so in that we will tell you how to just measure it and how to insert the Giddle airway. Laryngeal mask airway, usually it is used when there is failed endotracheal intubation or the procedure of the short duration, or the anesthetist is quite inexperienced, because for this to pass we don't need the direct laryngoscope, and even the junior anesthetist can pass the this laryngeal mask airway. This is one of the airway that is called as supraglottic airway. Why it is called supraglottic airway, I will show you here. Here you can see that this is just above the glottis. That's why this is called as the supraglottic airway. I have to show you that this is the laryngeal mask airway that is made up of the PVC, and here you can see that we have to inflate it with air. Okay. But here you can see this is not made up of the PVC because there is no air. You can see this is made up of the gel, This is called as the eye gel type. So actually it is quite easier to insert, and we don't need to inflate the cuff with the air. That's why this is much easier, much quicker. And the other thing is that it takes the shape of the contour of the larynx, so this is much safer as well. Now the endotracheal tube, here you can see the anesthetist has endotracheal tube in his right hand, and in the left hand he has this direct laryngoscope, because first we have to do the direct laryngoscopy so that we can see the vocal cords, and then we have to pass the endotracheal tube in between the two vocal cords. Inshallah, we will take your class on the airway management, in which we will teach you how to insert the endotracheal tube. Here you can see these are the preformed endotracheal tubes, and you can see these are not straight, there is bend. So actually what happens, if sometimes for example you are doing surgery on the nose and you have passed the orotracheal tube, if you are using the regular orotracheal tube, then it will come into your way, that will disturb you, and if you will try to push it in the other way, then there will be kink. So to avoid this complication, there is ready-made endotracheal tube which have bend in that. So this is nasotracheal endotracheal tube, and this is the orotracheal tube. How can you remember this? You can see north facing tube is basically the nasotracheal tube. So N for north, N for nose. And here you can see that if you are using south facing or the orotracheal tube, then you can perform a surgical procedure in this area very easily. And if you are using the nasotracheal or the north facing tube, then you can perform surgery here easily. Now the recent advances in airway maintenance, ventilating bronchoscope, because if you are doing bronchoscopy, so naturally it's how can you pass the endotracheal tube? In that case you can use jet insufflation. Here you can see this is the attachment from where you can pass the air, and these are the holes that air passes into the airway. Another thing is the double lumen endotracheal tube or the endobronchial tube. Here you can see that there are two channels. One channel is like here and the other channel is here. So if for example you have to perform surgery on this lung, so initially both channels are working and air is coming into both the lungs, okay, but once you reach up to the lung, and at this point in time you have to stop ventilation in this lung so that you can perform surgery. In that case, anesthetist will stop ventilation only in this lung and the other lung will continue to be ventilated. What are the complications of intubation? Very common, failed intubation, and naturally this is only by the inexperienced anesthetist. Accidental bronchial intubation. In this picture you can see that there is bronchial intubation because this tube is not within the trachea, rather this is into the right bronchus, because commonly the endotracheal tube goes into the right bronchus. Why into the right bronchus? Because this is much shorter and much straighter. So if that happens, the other lung is not ventilated and then it collapses. So just after passing the endotracheal tube, anesthetist has to auscultate both the lungs so that we have to confirm that endotracheal tube is within the trachea, not within the bronchus. Okay. Trauma to the teeth, pharynx and larynx is basically, this is the most common complication, because when you have to pass the endotracheal tube, you are using the direct laryngoscope, and if you are not using direct laryngoscope properly and putting pressure over the teeth, then these may be broken. Aspiration of the gastric content, this is very important because when we are passing the endotracheal tube, here you can see that there is a balloon. We have to inflate the balloon. That prevents the gastric contents to be coming into the respiratory system. But if there is a leakage in this and air passes out and it gets smaller, then naturally the gastric content that may come into the respiratory tract. And the other thing is that if patient is not ready, that means the milk per oral time, if that is not adequate, then there are chances of aspiration much more. Another complication that may be disconnection, blockage or kinking of tube. That's why there are alarms which are telling us that if there is any issue like this, then in the anesthesia machine there are alarms, so we have to be careful. And the other thing is that oxygen saturation that drops, so we have to be very vigilant about this. Delayed tracheal stenosis, basically that happens in the ICU patients, because if we have to pass the endotracheal tube for a long period of time, then because of this balloon there is constant pressure and then there is tracheal stenosis. Thank you very much.